All right. Can you hear me? Yes? Okay. Well, yeah, I like to move around. Well, thank you very much for inviting me and spending part of this beautiful Saturday here to learn a little bit about scleroderma. I do a lot of presentations for the medical community, and it's a little bit different than the patients, so please stop me and ask questions if there are terms that I don't explain or terms that you need a little bit more explanation. I do see a few familiar faces, so hi there. All right, so let's start. So this picture, it's the extreme. So there are different levels of scleroderma or systemic sclerosis. You will learn today, either for yourself or some relatives or friends. So, oh, okay. So systemic sclerosis, which is the name that is mostly being used lately, essentially means sclerosis is a scar, fibrosis is a scar, and collagen deposition is what a scar is made of. So all those terms, you will be hearing them frequently through our presentation. It is an autoimmune disease, which means that there are antibodies that will be attacking our system, either internally or externally. In this disease, there are antibodies that can be identified in the blood work. It's a connective tissue disease, which means that affects the soft tissues, not the bone itself, unless it's associated with another connective tissue disease like rheumatoid arthritis, in which case it can cause damage to the bones, erosions, or bone destruction. It has a worldwide distribution. It is estimated 100,000 people in the United States, most common in females, and usually the age of presentation is between 15 to 40 years old, but not limited to that. I see all age groups. It has a possible genetic and environmental component. Like all our diseases, we don't know the etiology. We think we're born with a genetic predisposition, and there's something else, maybe in the environment, bacterial, viral, that triggers it, that sets it on. So it is a vasculopathy, which means that it affects the blood vessel by making deposition of scar, collagen, fibrosis. So the lumen, which is the center of the blood vessel, will be occluded. So that's the primary cause of the disease. And it can also affect the skin by causing the same thing, fibrosis, scar, collagen deposition. Several things that are seen on this disease is the RAYNAUD'S. And the RAYNAUD'S is the small vessels of hands and fingers that get occluded by vasospasm. In addition to that, we will learn that there's primary and secondary RAYNAUD'S. Primary RAYNAUD'S is not associated with a connective tissue disease. So this patient does not have scleroderma. Secondary RAYNAUD'S is the one that you see on systemic sclerosis. And besides, in addition to the vasospasm, they also have the scar in the lumen of the blood vessel, so less blood flow can go through. Renal crisis. So renal crisis is the patient can end up in dialysis. They can have significantly elevated blood pressure because the blood vessels that supply the kidneys are affected. They're the lumen is very small, so not enough blood flow can go there. The blood pressure goes up. And the pulmonary artery, also the same thing. That blood vessel gets affected and the blood pressure goes up. The skin gets really thick. And the scars can also be seen in the lung, causing fibrosis. When there's a lot of fibrosis, it can also produce pulmonary hypertension. Also, the mucosa, which is the term that we use for the internal soft tissue in the esophagus, prevents the motility, the normal motility of the gastrointestinal system. They can have associated inflammation, but it's not an inflammatory disease like rheumatoid arthritis and other diseases. We even call it pauci-immune, which means it lacks inflammation. But on the hands, it can cause inflammation, and it can present with puffy, swollen, very painful hands. which can be the first stage of the process of the sclerosis or fibrosis of the hands. And synovitis means inflammation of the joints. So there we see a blood vessel, the lumen, the center on the right, it's open. On the left, it's occluded. This is vasospasm, but it's just to have an idea how small that lumen can get and how, with the Raynaud's, when it's very severe, they can have ischemia, which means lack of blood flow, and the tissue suffers. With the Raynaud's, the main trigger is the cold. So these patients have to keep their core very warm with scarves, and they should wear gloves to prevent this vasospasm from happening. Okay, so the diagnosis is mostly by adding criteria. The number one criteria is systemic, all over scar tissue or sclerosis. But the American College of Rheumatology, along with the European League Against Rheumatism, EULAR, in 2013 proposed certain criteria. Having the systemic skin diffuse thickening by itself can give you the diagnosis. But other minor things that the rheumatologist, when you go visit them, can help you form a diagnosis if it's not that obvious. There. And here's the point scores that they use to diagnose someone. I believe this will be available for you guys to look at, but telangiectasias, which I think we will get more out of going through the lecture and going over every single one of them. Okay, so here we talk about the primary Raynaud's, which I already explained, not associated with a connective tissue disease, and the secondary Raynaud's, which means there's an underlying collagen deposition or scar formation already in the blood vessel. In addition, we get the vasospasm, so more damage could potentially happen to the fingers if they don't warm up their hands or their extremities. 5 to 10% of adults have primary Raynaud's, but sometimes I think every patient with Raynaud's, primary or secondary, should see a rheumatologist to make sure they don't have a connective tissue disease. So there are potential 3 stages of Raynaud's. Blanching, which is when it becomes white, there's lack of blood flow going through. Purplish, which is there's already some tissue damage happening or going. And then once the patient realizes, either because it hurts or because, oh, my hands are purple, they warm their hands up and it becomes pink. That is called a reperfusion injury, and that's when the pain also can get worse. The secondary Raynaud's, as I mentioned, can have chronic, slowly tissue damage or destruction, and the skin, when it gets scarred and has less perfusion, it can develop loss of the fingertips or smaller fingertips, so their fingers can actually get smaller, and they can have contractures of their fingers, and here we have some hands with those contractures. And here we see the Raynaud's, the blanching, the purple stage, and the pink stage, and there's an ulcer. So that finger there in that screen didn't have enough blood supply on time, or the blood vessel is already occluded, so it develops some injury. It is very, very important, as the introduction said, to identify these patients early on to prevent amputations, to prevent losing an extremity. So we have to be very vigilant about this. We have to identify these patients quickly enough, and we have to also educate the primary care community to identify these patients quickly and send them to the rheumatologist. And when we are called for example, a hospital visit on these patients, we have to start medication very quickly to save those limbs. This is the same thing. We see the fingers are smaller due to the loss of tissue at the tips. Digital pitting is also some scar in the fingertips. from lack of blood flow and from from excess collagen or excess scar. They're called digital pitting scars. Here, also a repetition of the two types of the systemic sclerosis. One is the limited, the other one's the diffuse. The limited, it's mostly skin thickening below the elbows or below the knees. Both of them start with RAYNAUD'S. They can start with RAYNAUD'S. Also, nothing is perfect by the book. You may have a patient that may start without the RAYNAUD'S, but classically we see the patient who starts with RAYNAUD'S first and slowly develops other symptoms. In the limited, usually the progress is slow. It doesn't evolve from RAYNAUD'S to skin thickening and other things. In the diffuse, everything can happen at the same time or can happen very quickly from one to the other. Heartburn, because of what I already mentioned, the esophagus, for example, doesn't move well, and the sphincter, we have two sphincters, one up and one low, they have scar tissue, so they don't close as they should normally to prevent the food or the acidity of the stomach to go up. So these patients, one classical question in the clinic is, how many pillows do you use to sleep? And sometimes the patient's not even thinking about that, and they tell you 4 to prevent the reflux from or 3 or 2 to prevent reflux from happening. In the limited, later we can see pulmonary fibrosis that can evolve into pulmonary hypertension. They can have telangiectasias, which I will explain what that is briefly, and limited in general has a good prognosis. The diffuse, on the other hand, may not have as good as a prognosis as the limited. Everything happens very quickly. This is telangiectasia. So telangiectasia are abnormal blood vessels, are clusters of blood vessels that we can see in the skin, the face primarily. And we always make sure to examine their mucosa, their tongue, because if we see them there, that gives us an indication that they could be happening in the stomach as well. And in the stomach, it may be called watermelon stomach, and they can have microbleeds. And they are blanchable, so when you touch them, they become white because they're blood vessels, clusters of them. These are abnormal blood vessels that we can see, and they are classical of systemic sclerosis. They are dilated, they are engorged, and they're not normal. We see them in clinic. We can put a drop of oil or water and look at them. There are 3 main types of antibodies that we see in systemic sclerosis. One is the centromere antibody, which is associated with the limited disease that we talked about, and the other one is the anti-SCL70 or anti-topoisomerase, which is associated with diffuse disease. We always make sure to check the anti-RNase polymerase 3, because if we see that, that patient may be more prone for kidney problems. This is end stage, or it's advanced systemic sclerosis. I shouldn't say end stage, I would say more like the diffuse skin thickening. After some time of having this diffuse skin thickening, it can plateau and it can actually resolve a little bit. It can soften up. The patient on my right has difficulty closing her mouth. She looks like a young girl, but she's probably late 40s. Another end-stage manifestation is calcinosis, and this is calcium deposition in the soft tissues, and it can ooze through the skin. The problem with them is that they can get infected, so we have to watch them. And it's frequent in the limited systemic sclerosis. That's calcinosis. Vitiligo, or that salt and pepper appearance, is the lack of melanin because of the scar. The melanin dies, I should say. And we have there the salt and pepper classical appearance. We see some sclerodactyly, which is thickening of the skin of the fingers, and we have an ulceration there. The areas of the hand that are more prone for flexion or stretching. Those areas can develop ulceration. So here we have they're called the PIP joints. We can see almost all of them with some small ulceration. They are overstretched, and the skin, because it has a scar, doesn't have much to stretch. And we also have some puffy hands. There's a little bit of swelling in the dorsal aspect of the hand and wrist there. This is the first stage, the puffy hands. Here we start to see some skin induration, scar. And the next one is a diffuse scar or diffuse thickening. There's an entity called SINE, which means without. Scleroderma, SINE scleroderma. So this is a patient with all the internal problems or complications of a scleroderma patient, but nothing on the outside. And it's harder to diagnose these patients because they don't look like a scleroderma patient. But they can have RAYNAUD'S, the gastrointestinal problems. They usually have positive autoantibodies. They can have some telangiectasias if we look closely. And they also have the same risk of pulmonary hypertension, but it's later in the course. That's the watermelon stomach or GAVE. Those are all telangiectasias there. Patients with gastrointestinal symptoms, because again, nothing moves. Normally, the slow is the movement of the gastrointestinal system is very, very slow. They can suffer from overgrowth of bacteria, flatulence. They get full very easy. They can lose weight. They have a lot of heartburn, difficulty swallowing. They can have strictures in their esophagus, so contractures that needs to be loosened or broken by a gastroenterologist. Now we'll move on to pulmonary complications. We talked about fibrosis. We talked about the pulmonary hypertension. It's the leading cause of death in this time. Patients with pulmonary fibrosis can lead to, unfortunately, being dependent on oxygen. The one thing that, as a physician, we have to be aware is if the patient complains of chronic cough, dry cough, we may want to look into their pulmonary function test, which is a test that we do to monitor their lung function. It tells us if there's a restrictive pattern. It measures the diffusion capacity of the lungs, and it may indicate pulmonary hypertension. We do an echocardiogram, and if it's suggestive of pulmonary hypertension, the diagnostic test is a right heart catheterization. That's the accurate way to measure the pulmonary artery pressure. Very important, when we have the patient that we suspect has pulmonary fibrosis, which is a scar tissue, there's really no clear evidence that a medication can eliminate the fibrosis. But if there's active inflammation in the lungs, which can be called honeycombing, we could treat that patient and prevent further fibrosis with chemotherapy agents like Cytoxan or other. And a good test for that is a high-resolution CT scan. A CT scan, plain CT scan, can help us, but the best one is the high-resolution CT scan. They can do bronchoalveolar lavage, and it can measure inflammatory cells. And if we see significant number of neutrophils and eosinophils, then we suspect there's some inflammation going on. On my left is a high-resolution CT scan. This is a plain X-ray. Both of them have fibrosis. And this is how the fibrosis would progress. A healthy air sacs on the left. On the right, we have some inflammation going on, lots of scar tissue going on here, and on the extreme right lower area, everything is a scar tissue. So the pulmonary hypertension, there's a lot of pressure, nothing is moving very well. It can happen because of several things. The blood vessels are occluded, so there's not good blood flow, everything's under pressure. It can happen because there is fibrosis. So there are different ways that unfortunately patient can get a pulmonary hypertension. There could be thromboembolic problems, lots of clots forming because everything's low, the pipes are not open, so they can have clots that are forming. Okay, let's move on to the cardiac aspect. It's a late finding or it could be a late finding, and when the heart is involved, that could be a sign of poor prognosis. It is uncommon. The patients can have arrhythmias or problems with conduction in the heart. They can have heart failure, fluid around the heart, which is called pericarditis. And a large pericardial effusion is rare. It's more frequent, a smaller pericardial fluid finding. Renal crisis. So in the past, the leading cause of death was renal crisis. Not anymore, because we have medication to prevent this and to treat this. So this is one of the biggest findings in the systemic sclerosis or the scleroderma world, using these medications, because a lot of patients that in the past were not surviving now are surviving and living longer. So angiotensin-converting enzymes are the medications that can prevent this. Every patient with systemic sclerosis should be at least on a very low dose of this, or the highest dose that they can tolerate to prevent kidney problems. It can still occur, we can still see it in diffuse disease. I explained that in diffuse disease everything can happen so quickly, so we can still see these. Signs of symptoms of patients that can be developing renal problems, headaches. Patients could have stroke, heart failure, kidney. We monitor the creatinine, which tells us more or less how the kidneys are working. So we monitor that. We look at the urine. It's very important to get that urine sample every once in a while, and we see proteinuria or abnormal cells. That's also an indication or give us a clue that something is not right. Anemia, low platelets, all of that. With very early aggressive treatment, the outcome is very good. And even if the patient ends up in dialysis, with these medications, we can take the patient off dialysis if their kidney function improves, of course. So these are some factors of poor prognosis in renal crisis. If the creatinine is more than 3, and if it continues to go up, delay, taking a while to normalize the blood pressure, so the patient having this high blood pressure for a long time. It's more common in males, and it's more common in elderly scleroderma patients, and when the patient already has congestive heart failure. So a hypertensive renal crisis, it's usually when the systemic blood pressure is more than 140 and the diastolic is more than 90. And when we see an increase in the diastolic of more than 20. I already mentioned the other ones. We have to be aware. Not everything is always as we expect. Same as not all scleroderma patients, there's this population that doesn't have any outside features and is harder to diagnose. We can have a patient who can develop a renal crisis and never had high blood pressure. So we have to be aware of that as well. So we have to do the blood work and monitor the creatinine, the kidney function, and see if it gets elevated. So every time they come to clinic, or we should be doing this. And here we see a blood vessel that is occluded. So this would be the lumen. And all of that is scar tissue. Let's move on to musculoskeletal, the joints. The patients can have joint contractures, lack of range of motion because of the scar, the fibrosis. Earlier on, we can identify something that is called tendon friction rubs. When we move the joint, we can actually hear the friction, either with a stethoscope, or sometimes we don't need a stethoscope. We can hear it and we can feel it. and that means inflammation in the tendons. The patients can have muscle disease, myopathy. Myopathy is muscle weakness or some damage, but not with inflammation. Myositis, there is inflammation. The bone, the end of the bone also can get resorbed or destroyed. The calcifications that we talked about, synovitis means inflammation of the joints. And because everything is so tight or so swollen, the nerves that are there can get compressed. So they can have neuropathies. They can have a carpal tunnel, they can have ulnar neuropathy. And this is something that we see. So here we see loss of the fingertip. The bone is destroyed there. That's an X-ray. That's calcification or calcinosis. Oops. There. So this patient would have a shorter finger. So the myopathy and the myositis. Myopathy is muscle damage without the inflammation, and in the blood work they don't have a lot of elevation of the muscle enzymes, and we don't see that inflammatory response in the blood work, different from myositis where we see all of that and we see elevation in the muscle enzymes. The myopathy, because it's not necessarily an inflammatory process, it's not responsive to steroids. And in the myositis, they do respond to anti-inflammatories and steroid medications. As earlier mentioned, they can have overlaps or they can be associated with other connective tissue diseases like rheumatoid arthritis. And they respond to treatment for rheumatoid arthritis, like methotrexate, for example. And the most common compressive neuropathy is the carpal tunnel. So let's move on to treatment. Do you have any questions about the definition of the disease so far? Maybe at the end. So no, there's no specific therapy. Okay, this is the medication for the systemic sclerosis. We treat the affected organ system. So target for the area that is affected. So here on top, we have a blood vessel, and we have the lumen, and we have different, and this is busy, but I will make it very simple. There are different ways that medications are target. There's something called endothelin pathway, which is in excess, and endothelin can cause collagen production, and if it causes collagen production, will cause the fibrosis, which will cause the scar. So this is going crazy. They need medications to stop that. On the other hand, the prostacyclin pathway and the nitric oxide pathway are suppressed. So they use medications kind of like to stimulate those pathways. So these are the three different pathways that I mentioned and the medications that are addressing those areas. Treprostinil can be given as a continuous infusion. I have patients on that one. Iloprost could be inhaled or could be given IV. Epoprostenol is a continuous infusion. Endothelial antagonist, meaning against or trying to suppress that. Bocetan, ambrisentan, and phosphodiesterase inhibitors, Viagra, sildenafil, Cialis. So let's try to go through the organ systems and how we would treat them. For pulmonary hypertension, continuous IV epoprostenol, Flolan, and subcutaneous IV treprostinil can be given, are actually the first line of treatment. Inhalation of iloprost, endothelin receptor antagonist, Bocetan, an oral non-selective endothelin receptor antagonist, and the Viagra. All those medications could be used for pulmonary hypertension. So this slide is a little bit old. Oral treprostinil that you see there is available, is FDA approved. I have used it for my patients. Imatinib or Gleevec has been used to suppress fibrosis. So the scleroderma renal crisis, as I mentioned, lisinopril can be used, should be used to prevent and to treat the deaths or problems from the scleroderma renal crisis are almost non-existent these days. Losartan can be used, which is an ARB, having the same benefit. And the RAYNAUD'S, how to treat it. Number one, keep yourself warm. The core, and when I used to give this lecture in the past, I used to say, move to Puerto Rico, which is where I'm from. Do not smoke, try to exercise, it improves circulation. Other treatments for RAYNAUD'S, medical treatments, calcium channel blockers are vasodilator. Like examples are amlodipine, nifedipine, felodipine. Patients should be on a low dose or tolerable dose of these. I have many patients on antidepressants. They do help. Prozac is the one that I use the most. They have some vasodilator capability. They inhibit platelet aggregation, so they may inhibit clot formation at a small level. So when we are called for a patient with an ulcer or an ischemic finger, we want to save that finger. So the medication that we would use in the hospital is IV iloprost, which vasodilates, helps heal the damage that's already been done, and it prevents further damage. Anticoagulation, not necessarily for primary RAYNAUD'S, but for secondary RAYNAUD'S, a baby aspirin is very useful to prevent microthrombi and clots. Long-term anticoagulation, for example, warfarin and heparin, is not indicated unless the patient has another associated disease, something called antiphospholipid antibody syndrome, or if the patient has an underlying malignancy. Cyclophosphamide is chemotherapy and is something that we've used to prevent further fibrosis in the lungs. If we mostly submit patients to this chemotherapy if we know we can prevent further fibrosis. When we do the high-resolution CT scan and it shows active inflammation, honeycombing, we may use this and prevent complete fibrosis of the lungs. They have done lung transplants. Autologous cell transplant has been done, and there are some good results, even that it may prevent further skin thickening and overall function of these patients. Methotrexate is very good for musculoskeletal. Celsep, mycophenolate, I have used it to prevent further fibrosis of the lungs if it's not severe, if they don't need chemotherapy with cyclophosphamide. There's no clear evidence to prevent fibrosis, but there are a lot of studies going on, and there will be more to come. TGF-beta blockers have been described, and anthracytokine therapies also. Let's talk about the gastrointestinal system. So the patient should elevate the head of the bed to make sure they prevent the discomfort of the reflux. They should probably be on a proton pump inhibitor to suppress all the acidity and ulcers, bleeding ulcers. And all this inflammation from the acidity can cause strictures, and those are the ones that may cause problems swallowing, and they may need to be dilated by the gastroenterologist with an endoscope. Another complication, which I already mentioned, is the watermelon stomach, which can be treated with photocoagulation with an endoscope. Gastroparesis is when nothing moves very well. The food sits there for too long. The patient has bacterial overgrowth. They can have symptoms alternating diarrhea with constipation. When it's severe, we treat this patient with doses of antibiotic. Usually metronidazole, 2-3 weeks, 250 milligrams 3 times a day, or ciprofloxacin, 500 milligrams a day. Not indefinitely. We give them temporarily when they have the symptoms. It's good to take probiotics, to eat smaller meals. These patients, I send them to the gastroenterologist, the pulmonologist, and the cardiologist. So they have a lot of specialists that we work together, and we do frequent pulmonary function tests and echocardiograms, either once a year or every 2 years, to monitor what we cannot see when we examine the patient. They can tell us, I have more coughing, more shortness of breath, more reflux, but we make sure we do the blood test, the urine, and all these tests regularly. And they see the rheumatologist frequently. So we become family to each other. I think that's all I have. Any questions?